Good morning, everybody. Please take your seats. I think we're ready to start our first session on LAAC and EP-oriented considerations. My name is Davide Fabbricatore. I'm very happy to chair this session together with Jim Freeman. And as you're all getting ready, it's also my pleasure to introduce our first speaker, an old collaborator of ours, Davide Fabbricatore, a native Italian but now working in London, who will present AF burden and rhythm management relevance. Davide, please.
Good morning, everyone. The slide work, yes. So thank you for the invitation. Of course, this is a very relevant topic, especially because very recently has been published a consensus on the AF burden. So for the first time, we have defined the AF burden, which is basically the proportion of time spent in atrial fibrillation defined as a percentage of time over define time monitoring. So when I read this consensus, the first question that I asked myself is, okay, so we have a consensus, so now we can clearly connect the atrial fibrillation burden with the necessity of anticoagulation. Unfortunately, the reality is not this. How we measure the burden? So we have different technologies. Of course, we have the pacemaker and the defibrillator, but they are only a minority of our patients, and also in that case, the importance of the burden needs to be clarified better. But the technologies that we have available at the moment are basically three: the loop recorders, longest data. The specificity is not that great. Most of the time we have to reanalyze the episode ourselves. There is a lot of false positive episodes, as you can imagine. The Holter ECG is the best data that we can have, of course, so high specificity. Unfortunately, the sensitivity is not that great, because if the patient is having one episode per week and we're screening the patient only for 24 hours, you can imagine that we can miss the episode of atrial fibrillation. And in fact, the consensus statement that I showed you before states that we should screen our patient for 28 days. Now, I work in Royal Brompton. It's quite a posh hospital, but even then, we cannot do Holter ECG for 28 days. I would rather prefer maybe screening one patient for 28 patients for a day, or 14 patients for 2 days, more than one single patient for 28 days. And nowadays, we also have the wearable devices. They are very useful, great devices, but they are very expensive. I never recommend this to my patients, but I mention them. Of course, they are based on photoplethysmography, and when there is a suspicion of atrial fibrillation, they are able to collect trace, a single lead trace. So even in this case, the false positive acquire a lot of episodes. Why the burden has become more important? Because we know that the atrial fibrillation is not binary. It's not an entity like a paroxysmal, yes or not. You know that we have a patient with paroxysmal atrial fibrillation who have a burden of 1%, and patient with paroxysmal atrial fibrillation who have a burden of 100% if they have an episode of 24 hours and we are screening the patient for 24 hours. So you can't really treat these two patients in the same way. We know now that we have a pre-fibrillation status and then a diagnosed area of atrial fibrillation itself. And also our knowledge in terms of rhythm control strategy has changed. Yesterday, Tom has discussed about the AFFIRM trial, the ELAACC trial. So the AFFIRM and RAISE trial taught ourselves for many years that the rhythm control strategy is not superior to the rate control strategy. But of course, there were so many limitations. The anticoagulation was stopped. There was a very old generation of antiarrhythmic therapy. And so we knew that something was wrong there, right? But the paradigm change happened with other two studies later on, the CASTLE-AF trial and the EAST-AFNet 4 trial, with which for the first time we treat soon enough the atrial fibrillation, we reduce the burden, and this translated in reduction of heart endpoint, cardiovascular death, heart failure, and stroke. And then the paradox now is, in fact, the alone AF and diversion trial, where we, again, are thinking of interrupting the anticoagulation in patients who have a very low burden after our ablation strategy. Of course, these are very low-risk patients. So the question that we have to ask ourselves is, does the burden predict the severity of the disease? This is a patient with atrial fibrillation, persistent atrial fibrillation. This is another patient with persistent atrial fibrillation. For the one who are not used to electroanatomical map, pink means good atrium, so good EGMs. Not pink is disease atrium, is a scar atrium. So you can imagine that I can do whatever I want with this patient, ablation, medical therapy. I will probably reach the sinus rhythm. And also the management beyond that will be different from the other patient. Even if here I keep this patient in sinus rhythm, I'm not sure that I can interrupt the anticoagulation. This is something that we have to acknowledge. Is the burden a modifiable risk factor? Well, is modifiable, yes. We know that we can manage well the risk factors, physical activity, alcohol, obesity. With the arrest trial, we know that if we act enough, soon enough on the risk factor, we can reduce the burden of the atrial fibrillation significantly. Medication and ablation works even better, but is a risk factor? For what I've said before, probably not at the moment. So what the guidelines on the atrial fibrillation say in the management of the patient, we have to focus on two things, basically. We have to reduce the symptoms of our patients, and we have to reduce the risk of stroke. So I ask myself, okay, does the burden represent, well, the symptom of our patients? From this meta-analysis, you can see that basically a quarter of our patients with episode of atrial fibrillation are not symptomatic during this episode of atrial fibrillation. And the asymptomaticity increases if the patient has diabetes, or they have clinical kidney disease, or they have a previous stroke. They become more symptomatic if they have heart failure. We also mentioned that before yesterday. If they have had a catheter ablation before, most likely because I've changed the burden from persistent to paroxysmal, and so now the patients are more symptomatic. They feel more the episode because they are not all the time in atrial fibrillation. And also the use of antiarrhythmic, most likely for the side effect derived from that. Stroke prevention. Oh my God, this became even more confusing. Yesterday, Tom, as you mentioned, the Atrial trial, right? So in which we screen the patient with the devices, and there is no time in correlation between the episode of atrial fibrillation and the episode of stroke. But what the other studies that we have done more recently say? So the more recent trial that I want to mention are the loop trial and the stroke stop trial. I think that they're very interesting, and they represent the same aspect of the same disease, different aspect of the same disease. So basically, in the loop trial, we were screening the patient for a long time. And in the stroke stop trial, they were doing ECG, 30 seconds of screening basically, 2 times per day per 2 weeks. What happened in the loop trial is that the patient were found to have atrial fibrillation 3 times more often, but the episode of atrial fibrillation which require anticoagulation were considered beyond 6 minutes. But if you do anticoagulate this patient, you don't have a reduction of the stroke. In the stroke stop trial, actually, all the patients were found in atrial fibrillation with this intensive screening were started on anticoagulation, and there was a minimal but statistically significant p-value 0.04 of reduction of the stroke. What it means that the burden is important, because in the stroke stop trial, if you found the atrial fibrillation, that was over 60 seconds per day for 2 weeks. In the loop trial, 6 minutes of atrial fibrillation spread in such a long time, probably they have clinical relevance a bit inferior. So the take-home messages from this consensus is that the binary classification of the atrial fibrillation is definitely inadequate, is a useful tool for the treatment to see if the patient responds well to the therapy or not. It's insufficient at the moment to guide us on the anticoagulation. We can discuss about that later. We need continued monitoring, optimally for 28 days. I don't know if it's feasible in your hospital. And the threshold need to be clarified a little bit better. These are probably the 2 things that we are studying. It is important to standardize our approach also in view of future studies. So potentially the burden beyond 11% and episode of atrial fibrillation lasting longer than 24 hours are important for the stroke, for the incidence of stroke. And this is just the final provocative slide of mine. So this is a patient who come to from my lab like 2 months ago for a redo atrial fibrillation ablation. So it's all red. It means that the atrium is so scarred, there was nothing to ablate. The only thing that I wanted to do here, despite this patient had paroxysmal atrial fibrillation, so very low burden, we checked the appendage after, and you can see that with the contrast, there is probably, you can tell me better, there is probably a pre-thrombotic status in the appendage. So in this case, patient with symptomatic short episode of atrial fibrillation, so low burden, nothing to ablate, paroxysmal AF, but we decided to close the appendage anyway because we don't treat only the numbers, we have to treat the cardiomyopathy. Thank you very much.
Thanks a lot, Davide. We have time for a few questions. I can start by asking you your thoughts on burden and wearable. So you showed us very nicely the evidence and the lack of evidence currently on AFib burden to guide anticoagulation strategy. What are your thoughts on AFib burden and specifically on continuous monitoring to guide intermittent anticoagulation therapy? So you know there's a lot of theories about that and ongoing studies. Given the data you showed, do you think it makes sense? Do you see a future where some of our patients will take anticoagulation for a week if their watch tells them you're in AFib?
Yeah, I do that, in fact, especially for patients who don't want to stay on anticoagulation for lifelong, basically. I think that the difference is if the patient can afford that, the cost is quite high. At the moment, we can use also the Alive Core, which is quite cheaper, £100, and so they can have these strips of atrial fibrillation. I think that the difference is that I told you that 25% of our patients with AF, they don't have symptoms of AF. But some patients do have symptoms, and you can correlate the symptoms well with the atrial fibrillation. So in that patients, I also educate my patients to, feel their pulsation. If I feel that, the symptoms correlate well with the atrial fibrillation, I do intermittent anticoagulation based on that. Otherwise, I think that the optimal strategy will be definitely the wearables. But nevertheless, you have to base your consideration also on the Charles Bass score. For some reason, it works, even if it was done in a previous era.
Very nice talk. I'm fascinated, or actually was fascinated by the potential of an iWatch to detect AF and maybe also after ablation try to help if anticoagulation is needed. But the specificity that you showed here, 34%, is extremely disappointing. So can we forget about watches for monitoring for AF, or what is your thoughts, or is it a question of getting better technology, or?
Yeah, I think it's a good idea. I think that they are a good tool. The fact that we have 34% of false positive doesn't mean that they don't work well. They probably work too well, and so sometimes you have to reanalyze the traces, but it doesn't mean that they don't work well. So you can recognize the episode of atrial fibrillation. The problem is more like if the patient is having also atrial ectopies or other things that can confuse the algorithm. But I think that, yeah, they are a great tool, for sure. There are many things happening. I think that in the ESC conference last year, they were talking about all these AI algorithm, new devices to use, stethoscope, iPhone itself. So I think that the future is there.
I mean, I think a lot of the wearable technologies can also be really useful once you have a diagnosis and once you kind of clearly establish when people are having it, and then you can use it for surveillance. So, we often use it for after ablation rather than establishing a diagnosis that way. You have to confirm it with something more sort of, I guess would say medical grade. Can I ask, so you throughout the number of 11% burden as being important, where did you get that? And
it was a meta-analysis, but they are all retrospective data.
Okay.
So it's not, as I say, the consensus say that we should focus on the burden as a percentage and probably try to understand the new thresholds, and this could be potentially one of them, but it's not that has been, you know, validated in randomized trials yet.
Yeah, that's a high burden. And so, I mean, for those not in the EP space, Jason Andrade's made a huge push for this AF burden metric, just to try and understand when we should be intervening symptomatically and otherwise. But I think we still have a lot of work to do to understand burden and how, kind of what our thresholds are for stroke intervention.
Yeah. I think that the burden becomes more important. The burden is higher also because you should document the longest episode of atrial fibrillation. Having a burden of 5% with one single episode of atrial fibrillation is different than having a burden of 5% with many episodes of atrial fibrillation. Yeah, most likely that's also the reason why.
Great, thank you.
Thank you.
Thank you. All right, so I'll introduce Tom. So Tom will be talking about imaging the left atrial appendage, the EP perspective.
Thank you. So, imaging in EP procedures, I didn't choose this title. Someone else was on the program, but we look at the appendage the same way everybody else does. But there are some considerations, I would argue, within EP procedures, which I'm happy to share with you if the clicker feels like cooperating. You just use this, right? There we go. All right, so if you think about procedural steps in our EP cases where we might be doing LAA closure and something else, I don't think it's anything spectacularly different from what you might imagine. We do groin access transeptal puncture, we size the left atrium, the left atrial appendage. We do something else potentially because nowadays if we do LAA closure, it's not necessarily only LAA closure. Of course, we might be doing an ablation meanwhile concomitantly, and then we deploy the device. The first step, imaging, although it's not related necessarily to imaging of the left appendage, I do want to stress that it's critically important, and I think the entire field of EP has moved to the vision that doing a procedure without echo-guided vascular access is no longer a defensible position in 2026. I hope this is the same in the IC space. I don't know, I'm guessing it is. But obviously, the lower risk of vascular complications is the key driver, as we have seen, for example, in closure with AF. The vascular complication rate is not negligible, is in my perspective, a missed opportunity. Same, of course, for the transeptal puncture, echo-guided transeptal puncture, where I think in the LAA closure space, everybody was doing echo-guided transeptal puncture from day one, because obviously you need the echo anyway to image the appendage, to size the device. And then there's discussion about GA versus sedation, which I'm not going to go into for the purpose of this discussion, but we do use GA for the pretty much all cases we do. So the vascular access is already mentioned. We have a consensus document out about this, strongly supporting next to a lot of management strategies for difficult access, strongly supporting the idea to use ultrasound for all percutaneous vascular access based on good solid data. There's been a randomized study published last week, I think, which again was supportive of the idea. And the other thing in terms of access is the transeptal puncture, of course, and there we always discuss about location, just a bit like in real estate, location, location, location. In EP procedures, the reason I mention it and the reason I highlight it is that if we are doing concomitant procedures, it's of course not necessarily the transeptal puncture for the LAA closure we're trying to optimize. We're going to do a transeptal puncture that is useful for everything else we might want to do in the case as well. And for example, if you want to aim for a particular lido, and especially for very particularly posterior puncture, as has been advocated for many LAA closure procedures, then you might get into trouble accessing, for example, the right inferior pulmonary vein. And so we'll aim typically for something that's a nice compromise, and this means we'll need devices that accommodate, for example, a potentially suboptimal transeptal access from the point of view of appendage closure. For example, the devices that allow you to push a little bit to push a little bit against the wall of the appendage to reposition the device, ideally using steerable sheets as have been introduced to the market recently. And again, the reason this is a reality is because we are, especially in the US, seeing an incredible uptake of concomitant procedures, concomitant LAA closure procedures, based in no small part on data from the option study. So back to imaging, what do we do in our lab? In our lab, we have developed a very standardized workflow for AFib ablation, which we've called the conveyor belt, which is based on imaging. And depending on the technology we use, this may differ a little bit. We may use 3D mapping systems. We may use more angiography-based methods. But the common element is we build a 3D model of the left atrium, and we work on that. And the nice thing, of course, is that this 3D model is often also useful for the purpose of appendage closure. And this is one approach we've worked on a lot. We've been using it for 15 years, which is 3D rotation angiography. 3D rotation angiography, which will give us a CT-like model of the left atrium, of course, with the benefit of having the 3D model integrated in the fluoroscopy and real-time available for analysis in the lab. It allows you to do everything you would expect to be able to do from a CT scan. You can segment, you can build a 3D model, you can rotate it any way you see fit, and you can, for example, one of the nice things about this, about it, is you can use it to identify your ideal workflow using the X-ray. For example, due to the fact that it's integrated in the X-ray system, it's a simple matter of moving the X-ray tube, and the model will rotate together with your X-ray tube, and you will understand what the ideal visualization angle of the neck is. You can, of course, measure the diameter in any orientation, as you can do with CT, as you can usually also do with 3D TE, provided the image quality is good enough. And then you can choose the device size based on 3D measurement rather than conventional 2D TEE. And finally, what it may allow you to do, and what we've done and validated in the study, is it may allow you to do procedures without TE, using only this rotation angio workflow. So here are some examples of measurements of the left atrial appendage. And again, the scenario where 3D measurements really shine are, of course, scenarios where the appendage is extremely eccentric, where the shape of the appendage is such that standard measurement planes may underestimate the true dimension of the left atrial appendage, and using 3D measurements allow you to truly understand the proper dimensions and allow you to choose a device, for example, not on the maximum or minimum diameters, but on the average diameter of the appendage. Finally, something we don't do in clinical practice, but something you might imagine doing research on, it also allows you to fuse 3D imaging modalities, allows you to, for example, visualize how a device might look in a particular appendage. So as mentioned, we did study this approach, and to study the accuracy of 3D imaging compared to TE, and to study the feasibility of this workflow for performing procedures without TEE, again, without going into the specifics. What we found, as with other 3D imaging studies, is that there is a bias, a predictable bias, a systemic bias of higher estimation of diameters on 3D measurements, which is about 3 millimeters if you compare it to 2D TE. Finally, before I show you some examples, so the standard workflow, let's say the treatment path of our patient, as shown already, echo-guided access, groin and transeptal puncture. Then if we do a PV isolation, it will be ICE or TE guided PV isolation. And then we do the LAA closure, depending on the image modality we have, supported by ICE or TE, procedures under GA. And importantly, if we do concomitant procedures, we measure the left atrial appendage, ideally, of course, before the PV isolation, because as you know, there's some data out there, especially with RF ablation, indicating that RF ablation can cause edema formation of the appendage and can distort your measurements. We studied this also in the era of post-field ablation, and to our enjoyment, we found that post-field ablation did not seem to affect the appendage a lot. So what we found was that probably you can use the measurements even after the ablation of the appendage to size your device. And then just some examples from real life. This is from a live case we did a while ago. A very famous Belgian intervention cardiologist here. I don't know if Lisbeth is there. She is. So the case Lisbeth and I did about a year ago, I guess, to show you the rotation angio approach. So what you see there on the left of the CT of the imaging screen are the segmented images showing the MPR reconstruction, showing the device measurement. And here you will see the live overlay, and what you will see and hopefully appreciate is the nice match between the angio that I will inject, so the contrast injection, there we go, and the reconstructed segment model. You can see that it's almost a perfect fit, so you can perfectly well imagine that such a 3D model may be suitable to guide your device implant even without using TE. Here's another example from a live case showing deployment of the device. We put a line there on the 3D model where we would like the landing zone to be, and we will deploy the device. I think this is still Watchman. This is a pretty old case already, where we deploy the device and we can appreciate that our device is where we want it to be. And finally, another example or another approach is to use ICE. And ICE, of course, is also not unfamiliar to all of you. One of the unique applicability or applications of ICE in the EP space is that we can have integrated ICE in our 3D mapping systems. And this allows us to do things like you see here is machine learning-based automatic segmentations of the left atrium, which is using the ICE images to generate a 3D model. And then, and what you see there on the screen is the 3D representation of the imaging plane of the ICE probe. You can appreciate and understand the anatomy easily, even without necessarily having a lot of ICE experience by integrating this in the 3D mapping system. Can we go to the first marker? Yes, there we are. So you can go to the second marker, please. So here, for example, is the end of our PV isolation procedure. We finished the 3D model is there. We switch over our access to the Watchman delivery system. And then we'll go to the next marker, please. We're already a bit out of time. Yeah. So here, now I can use this 3D model and I can scan around using my ultrasound, using the ICE catheter to understand the geometry. Let's go to the next marker to do the measurements, using the ICE to do ICE-based sizing of the appendage. And then to do ICE-based deployment, delivery of the appendage occluder, and finish the procedure. Let's go to the next marker. And there we put the device and we can finish our case. So take-home message in our lab, our EP procedures, including LAA closure, are echo-guided everything, which eliminates access complication risks. Transeptal, as indicated, depends on what else you might need to do, and I think the availability of steerable sheets have dramatically influenced our reluctance to use, let's say, suboptimal transeptal positions. Depending on the device design, for example, using Watchman Flex, which is a device I use a lot, we size, but then I use the maximum reasonable diameter I can think of to fill the appendage. And then, as shown already, we tend to use the anatomy of the appendage a bit to position our device. Thanks a lot.
Tom, that was great. Thank you. So I'm curious what the practice is in Europe. In the US, there's new universal use of ICE for AF ablation. And then I've been interested to see, we thought that there would be rapid adoption of ICE-only left atrial appendage closure procedures and concomitant procedures. And we've seen that actually kind of hasn't been the case. There are a lot of people still using both ICE and TE. Is that commonplace in Europe as well? So the numbers are about 20% of cases of left atrial appendage closure cases involving ICE, but about half of those are ICE and TEE. So in our lab, we'll do these cases. We'll get a CT in the week prior to clear the appendage and clearly understand the anatomy before ablation, so we understand the size of the appendage. And then we'll do just ICE-guided only procedures. So like how much is that taking off here in Europe?
Well, first of all, ICE-guided procedures in general, PV isolation or LAA closure is not that pervasive in Europe due to budget concerns and budget constraints. And second, your observation is correct. I also see operators, even those that are using eyes to guide the PV, to consider TE for their LAA implant. For me, it's a matter of being inside or outside the comfort zone. So if you're doing PV isolation using eyes, typically you can use the right-sided axis only. You can stay on the right side. You do what you are already trained for. You visualize the atrium, you visualize the veins. But then if you want to go and do the LAA closure with the eyes, ideally you want the eyes probe in the left atrium, and you need to learn a little bit new angles, new stuff. So that's why I thought that 3D integration was so useful. It helped me a lot, for example, to understand how to manipulate the eyes probe, because the images are not images you're used to seeing. And if you have the option between somebody doing the TE for you and showing you what you've been seeing for the last 15 years, and it's super straightforward, or having to relearn something new, I guess most people tend to stick to their comfort zone. At least that's my interpretation of what's happening.
Yeah, I mean, I love it. I like having control of the imaging myself. It's sort of made a procedure that's become a little much more interesting, but there's a bit of a learning curve. We actually did overlap for about 6 months to try and figure out how to get the images. And of course, with 3D, and our industry partners here are working very hard on 3D technologies where you don't have to have quite the expertise. But.
Yes, James, I think your comment is right. I mean, just probably one of the more fortunate in Europe, because I use eyes all the time, and I use eyes and not just for catheter ablation, for appendage closure. You need just to at least, I mean, just in my view, to place the probe in the left side. I mean, just you can use the same hole, or maybe you can even do the two transeptal punctures, just to have much flexibility, and you're free just to move the two sheets. But I think that eyes, even though eyes can give you just less views as a TE, but at the end of the day, if you look at the clinical outcome, the result, I mean, just the success rate is still the same. I mean, just you have almost all the time with perfect sealing and a perfect placement of the appendage closure device.
Yeah, we've actually had cases too where I wish we had an ICE probe in. We're doing TE guided where the imaging is not ideal from the esophagus, and I don't know, we've gotten facile enough with it that I think you can really get remarkably good imaging from inside.
The other issue is the cost. I mean, just and remember, this is what probably prevents people from adopting ICE currently in daily practice.
And I guess the other element, and maybe Jens-Erik you'd like to comment, is that potentially, if we forget about cost for a second, potentially upcoming improvements in technology, high-resolution imaging plus for the eyes may allow right-sided imaging to be done by eyes again.
Exactly. Those catheters are expensive. I mean, that's the challenge, and so I think it's really important that you.
I would say, Tom, you have very easy access to GA, and that is definitely not the situation in many centers. So, for instance, in the Nordic countries and also in Italy, I think eyes-guided LAAC is the dominating workflow. And it makes things logistically much easier. I think it's also very convenient for the patient just to have the procedure done in local anesthesia. You don't have all the post-anesthetic recovering and things like that. And there is a learning curve for eyes, and as pointed out, we go to the left atrium, but we now have the 3D eyes probes, and that will allow us to do less manipulation with the eyes catheter. So in many cases, you will be able to be in more or less one position in the left atrium, and from there, by digital steering the image planes, you can get all the relevant views. So the technology is being advanced, and I think it will be easier also to do eyes. And then there's the issue, of course, of economy, but if you make the calculation that you don't have a full, you don't need a full GA team, you don't need a separate T operator. I mean, it can be, at least when we did the calculation, it was cost neutral to go for an ICE-guided approach, so it is possible. But of course, if we could bring the prices down and have also re-sterilization of the probes, that will facilitate that.
I agree. This strongly depends, of course, on how reimbursement is organized. In your experience, does 3D ICE allow RA imaging, or will it still be too much of an issue with certain septa or whatever?
Not at the moment. We have not tried. I think that's something that should be looked on systematically, but I would still, I mean, going to the left atrium, you get extremely good images, and of course, in the beginning, it's a challenge to cross with the catheter to the left atrium, but it's also a matter of a learning curve. So I'm not sure that this will be around the corner just to do imaging from the right atrium and get very good images, but let's see.
I mean, our imaging partners are definitely working hard on it. It's challenging, though, with the membranous septum. The image quality definitely degrades, and it's just not quite as good. But I should say, too, the outcomes when we've looked at ICE versus TE in the NCDR registry, the outcomes are very similar. We've seen a small signal towards increased risk of pericardial effusion, likely with the crossing over and the manipulation of the left atrium, but that was from kind of early ICE use, and that's all 2D. So.
Can I just one short question? Now that you have moved to PFA mainly, I think, isn't that a reason again to go back to GA, to general anesthesia, or not?
Well, there are some challenges with PFA, but many regions have successfully implemented sedation workflows also with PFA, so it's certainly manageable, it's certainly doable also with PFA. You're talking of course about muscle contraction, diaphragm contraction. It's doable, it's manageable, and I don't think it will be prohibitive for the use of sedation.
100% use of general anesthesia essentially in the United States, so just different. Assess necessary. All right, well, we should probably move on.
Yep.
So our next talk will be EP-specific considerations in device evolution by Claudio Tondo.
Morning. Thank you, Jim. Thank you, Tom. I think that we're going to discuss how just to manage a patient, in which we need to ablate atrial fibrillation and even concomitant the atrial appendage closure. In the last few decades already, we have quite a robust data showing the feasibility and safety when you want to combine the catheter ablation, atrial fibrillation, preventing stroke and reducing the risk of bleeding. In the majority of cases at the very beginning were just, a one single center experience, but, different operators have, confirmed the trend that you can reduce significantly both the bleeding risk and the stroke risk, and by using in the past, and then we can to discuss the role of PFA, radiofrequency, or cryoablation plus appendage closure. So let's move, into the PFA world, which is really a revolution in the EP field. So what is the hypothesis to combine PFA with the left appendage closure? We have a different, PFA devices, and I think this is not the issue because you can easily and properly isolate the pulmonary veins, or maybe just, walk outside the pulmonary veins if you deem that it's beneficial to patients, especially in persistent AV patients. Usually, PFA can reduce the procedure time compared to RF or even with cryo. PFA has the potential to reduce complications related to energy source, especially compared to RF, and this is probably one of the major advantages of using a PFA. This is, could be really useful for frail and older patients. We have discussed yesterday, especially the category of patients included, for example, in a closure AF. And therefore, if we have the chance to use a much more safer modality of performing catheter ablation that will taken, and obviously this patient population usually are the good candidate for the concomitant. There are also some, technical reason behind this. Apparently, PFA, if you go for a PV isolation, is not completely dependent on vein occlusion, like cryo, for example. And the single transeptal puncture probably can be more, easy just to do for suitable appendage cases. As we discussed before, you also can do the dual transeptal puncture if you use ice and guide the catheter ablation and the subsequent appendage closure. Another debatable issues concerning the potential edema that can arise after ablation, especially the less superior pulmonary vein at the common reach, which was one of the issues concerning the concomitant. That means in a single procedure, catheter ablation plus appendage closure. Apparently, PFA reduces the entity of edema. It's not zero, because it's still there. But at least probably this, cannot lead to a change in the sizes of appendage. But one of the suggestions, anyhow, regardless the energy source that you use, it's, to reassess the measurement after PD isolation. Apparently, PFA might reduce the PD device leak, and this probably suggests that you also can electrically isolate the appendage, reducing obviously contractility, and one of the potential secondary trigger for atrial fibrillation. If you compare the main energy sources, this is one of the first investigational studies by comparing the PFA with cryo as a historical data and RF. At the end of the day, the success rate is almost the same, but the procedure, time is overall just less. We have had the initial experiences concerning the concomitant use of PFA. The majority of these experiences are related to the use of the pentaspline PFA catheter. You can also appreciate the right end of the slide that you might have a slight increase in procedural time, obviously, as compared to the appendage closure only, and a slight increase in fluoroscopy time, at least, if you use eyes for the majority of time. So the potential advantages of using PFA are there, and probably the future will tell us that this approach is, safer than the previous experience. Already we have heard about the option trial, as in the US, this was a boost to increase the concomitant. That's not the reality in Europe still. And obviously, this is something that probably is related to the reimbursement, again, in the majority of European countries as compared to the US, unless you have a local agreement to have a sort of increase of the reimbursement just because you use PFA and not other energy sources. So the option trial, already mentioned that was non-inferior to oral anticoagulation with respect to the composite of death from any cause stroke. So this is something that probably needs just to be mentioned, especially in Europe. This has been accepted last year in our rhythm. There's a combination of left atrial appendage electrical isolated plus the closure, and the PFA might create again less edema in the left superior pulmonary vein region, reducing the risk of peri-device leak. So after propensity matching with historical data coming from RF, that actually it takes us, almost 10 years ago, we published the BELIEF trial in which, we demonstrated the superiority in terms of clinical outcome if you electrically isolate the appendage and then you close, as to compare just the simple occlusion of the appendage. The procedural time, again, is less with the PFA, and although, at least in this experience, the overall PDL data incidence was lower with PFA, the clinically significant leaks were rare and comparable, especially in the range of the 3-4 millimeter. So this suggests that you can safely use PFA, and please note that this was an experience in long-lasting persistent atrial fibrillation. So we, beyond the PVI, we extend ablation of the posterior wall. And, I think that you can perform this safely with the PFA. Just the last slide, I think, we mentioned the 3D probe eyes for the procedure. And it's just one of the examples. We have the privilege to use the 4D. And let's see, the future obviously can help us to simplify and, giving us the better view, not only the left atrial, but the appendage ratio. So in conclusion, PFA has the potential to overcome traditional challenges associated with other AF ablation techniques, such as procedural efficiency, energy-related complication, and maybe the post-procedural leaks. Long-standing, persistent AF patients who are, the most difficult category of patient to be treated and ablated, but probably if you extend your ablation procedure with the PFA, you can also safely occlude the left atrial appendage, hopefully with a lower rate of PDL at the follow-up. Thank you very much.
Thank you very much, Claudio. While we wait for Domenico, please.
Thank you for the presentation. So 2 comments. First of all, the edema on the ridge. So this is not our experience with less edema. I think we see quite a significant amount of edema after PFA, and also other studies. I think Tom also reported a certain degree of edema, although the message in the paper of Tom is that the edema that you see doesn't match with the landing zone. So, so you see edema on the ridge, but then it doesn't impair the deployment of the device, especially for certain devices like Watchman. Then the second consideration is about durability of isolation of the appendage, because we have this paper showing that 5% of isolated appendages remain durable during follow-up with PFA. And so I feel that it's for sure easier to isolate the appendage with PFA, but then I don't know how the impact is going to be in the long term. And then once you put a device in the appendage, it's not going to be that easy to re-isolate the appendage unless you approach it from anterior, Bachmann, and so with an extensive ablation of the anterior wall. So just your comments on that.
Yeah, thank you, Domenico. I think that concerning the electrical isolation of appendage, we need to take into account also the different catheter design. Because I'm not sure that we have the same effect if you use the pentaspline as opposed to the balloon in basket catheter, for example. And you know, we just started to use it. Actually, next week for HRS, I do a live case by using the Volt with the new AMOLED 360. So let's see. I mean, just if this can obviously offer a much higher success rate. I completely agree that we still have a resumption of the electrical activity after an apparently acute effect on electrical isolation. But again, it depends on the device. If you use a dual, for example, the dual energy sources device is not the same if you use the pentaspline. The pentaspline probably is not the best catheter design to promote isolation of the appendage.
Can I just add too? I think how you do the pulmonary vein isolation matters probably. So in the U.S., there's a lot of discussion around not doing the sort of deeper lesions, the olive lesions with the pentaspline catheter to avoid edema in the landing zone. So trying to kind of modify a little bit how you do things for concomitant procedures. And I couldn't agree more. There's big differences between catheters in terms of the ability to deal with some of these anterior structures like the left atrial appendage and the mitral line as well, where we've seen very variable results depending on catheter.
Martin?
I'd like to touch a different aspect of what you've shown, and that is where do we see the future if we combine LAAC with rhythm control by PFA. And I would like to advocate the idea that it's not just the EPs learning how to do LAAC, because I think the more complex procedure that we have here is actually closing the LAAC successfully, not necessarily doing the PFA with the 4 veins. And we all accept automatically that the biggest clinical problem for these patients that we're talking about is actually keeping them in sinus rhythm. That's not my clinical experience. There's sort of an optimism now, like once we say rhythm control is the way forward for this 80-year-old patient, he goes for a second or third ablation. We talk about isolating the LAA, whereas if you ask the patient if he is in frequency control, probably his most worrisome idea is how can I prevent stroke, and possibly without NOAC. So I think these fields have to merge, and it's just going to be workload. If you see the perspective of how AFib will rise with the aging population, everybody is involved here. And we've done that at my center because we work closely together. And I think we need to be much more involved with the whole pathway of these patients. And we need to optimize LAAC, particularly in this field, with the CT planning, with the edema issue that we have, with the work process to build cath labs that can do structural EP, and also for us as interventionalists, learn from the EP to do the PFA for veins and then have an optimal LAAC. I don't know if anybody in this room also has started that way. But we always talk about this separately, huh? And LAAC is a more complex thing here.
Yeah, no, I completely agree. I think one of the problems we are talking about persistent, long-lasting, persistent AF patient. Probably we need to intercept them, much earlier, just preventing patient just to, increase the likelihood to become persistent. This is just one of the issue. And I agree. I mean, just those kind of patients quite frequently come back to the office just because of recurrences, and then EP having obviously a different approach, a different view. We try just to repeat ablation, just with the aim to keep the patient in a sinus rhythm, and sometimes quite a frustration. I mean, just because you try just to get rid of atrial fibrillation just by doing mitral isthmus, reflying, posterior wall, and then appendage electrically isolated. I understand that probably not more than 3-4% of cases there are secondary triggers from the appendage. So probably it's not really one of the main anatomic locations that we need to look at. But still, there, I mean, just one of the problem that we need just to face.
Okay, so I do believe we need to move on. A thought-provoking idea from Martin, but we're running a bit late already. So well, I was in a debate, Martin, in 2024, and I said before the end of the year, PFA will allow non-EPs to do PVI, and I think you proved my point. I defended that position. But we do need to move on. And for the last speaker in our session, I would like to invite Laurent Roten, who will discuss integration of LAAC with ablation strategies. Laurent.
Okay, dear colleagues, dear ELAACC committee, thanks for inviting me to this session. So I have to talk about strategies in AF ablation and how to implement this with LAO occlusion. So I'm an EP, so at the center of my procedures probably is ablation, and so if thinking on how to position LAO occlusion with regard to ablation, we can do it before ablation, we can do it after ablation in concomitant procedures, but we can do the same with sequential approaches. And then also keep in mind it's not only the first ablations where we may do LAO occlusion together with, but quite often it's also during redo procedures, and things may also be a little bit different in those kind of procedures. So first thought is what should we do first, LAO occlusion or ablation? And I think probably the best role model of doing closure first is this kind of patients that have a thrombus that keeps being there and doesn't resolve despite anticoagulation, and you want to go for ablation, and of course you should not do it as long as the thrombus is there. And so that's where you could do the thrombus trapping procedure. And I just want to cite here the French Trappeur registry, 53 patients who had a LA thrombus, and with a kind of a no-touch workflow, this appendage was closed with different devices. And they had quite decent results with very few adverse events. There was just one stroke among these 53 patients. So that's, I think, one thing where you can do LAA occlusion first. But then if you have already occluded the appendage and you go for an ablation, that's what may happen. And this is from a small also registry from Switzerland, 17 patients who already had a LAA occluder in place when they went for the ablation. So the majority, 70%, was a disc and lobe LAA occluder. And during pulsed field ablation to isolate the vein, in about 1/3 of patients, there was this kind of interference on the catheter, which also led to abortion of PFA delivery. And that's something you can manage. You can reposition your catheter, or sometimes you need to take another catheter. But in what actually happens during such interference, that's what you can see here. That's an in vivo study, and you see you have arsing and formation of bubbles, and that's something that happens with different PFA catheters, but also with different types of occlusion. It's a class effect. And what's the sequence of this clinically, we don't know. It's probably something that you should avoid, to have this kind of arsing in the left atrium with bubble formation. Now, going more into details about occlusion first versus ablation first, there's actually one trial who randomized this in 100 patients each, and the primary endpoint was stroke, TI, DRT, significant bleeding or death, and rehospitalization. And you can see here that clearly occlusion first was the better way to go in that trial compared to ablation first. If you go into the supplement and look why this is the case, you can see that those who had ablation first had a higher rate of DRT and strokes numerically, which triggered the difference in the primary endpoint. And actually what happens here is the ablation first group, the peridevised leaks were much more frequent numerically, acutely, but also during long-term follow-up. And we already talked about this. There was a rich edema in the majority of patients, which you can also see in that picture here. But keep in mind, this is an earlier study, and all these patients had radiofrequency ablation used. And we now have moved, the field of EP have moved to pulsed field ablation. And with pulsed field ablation, there is still some kind of edema formation. We heard about that, but it seems to be a little bit less extensive. And in particular, it doesn't maybe affect so much the landing zone where we go for the ablation, for the implantation of the occluder. And very recently, there was that's from Deviner's group. They have looked into this after concomitant procedures with PFA ablation, so ablation first and LAA occlusion second in over 200 patients. And they used a very elaborate workflow with CT imaging, AI planning, and again, eyes imaging just before deployment of the LAA occluder. As you can see here, they didn't have any significant leak during, in all those over 200 patients, so it seems feasible. And then that's another thing that makes me uncomfortable. So if I have a case where I do LAA occlusion first and then manipulate in the left atrium or have to do cardioversion, I always have the thought that may risk a device embolization. It didn't happen yet, and I didn't find anything in the literature, but that's something that you may also keep in mind when you do it this way. The next coming to concomitant or sequential sequence of the procedure. I think the best data we have so far is clearly the option trial. Just keep in mind 40% were concomitant and 60% were sequential in that trial. And in both of those approaches, the success rate of LAA occlusion was extremely high, no difference here. If you then look into the adverse event rate of those that were kind of stratified into the concomitant arms, so in both arms, in the combined ablation and LAA and ablation only, there was a concomitant stratification arm. If you compare the adverse event of those two here, you can see that these were very low. It was even more pulmonary pericardial effusions in the ablation only arm. So it seems to be very safe. Of course, if you do it sequentially, you have a second ablation procedure or a second occlusion procedure where you will have all the risk of adverse events because you need a secondary access and secondary transeptal puncture. With regard to efficacy and safety in the option trial, that's a sub-study. Either way, with concomitant or sequential, you have the same effect, so there is no difference regarding these endpoints. Now, we talked about this yesterday already, which patients are the best where you will choose maybe a sequential approach. I think if we do ablations in AF patients, our goal is to get rid of AF, and we're quite successful, especially in paroxysmal AF, and we talked about alone AF and ocean AF. That's the most recent meta-analysis, and you can see here that obviously you can probably stop anticoagulation in apparently successful cases, and overall the ischemic stroke rate here in events per 100 patients is very low at 0.23, and just a remark here, in those patients with higher CHA2DS2-VASc scores in those trials, it was very similar. So these are probably the patients where you can do a sequential approach in those in which ablation is going to fail. A concomitant procedure maybe is something that you may envisage in patients that have a high risk of bleeding or for lifestyle or other reasons want to avoid anticoagulation as soon as possible. And that's, I think, where Option and Champion AF inform us very good on what to tell the patients and what they can expect. Now, the last thing I want to cover, we already talked about this, is isolation of the left atrial appendage as part of an ablation strategy. And there are different ways how you can do that. You can just selectively isolate the left atrial appendage. You can do an anterior and a posterior line to isolate a larger region, or that's what I prefer to do in desperate AF ablation cases, is to isolate the complete left atrium. And here's such an example of an isolation of the left atrium. So if you look at the uppermost tracings, that's the ECG, it's in AFib on the left upper side. Then in the middle, that's the artifact of pulsed field ablation, which isolates the left atrium. And on the top right, you see that the patient is now in sinus rhythm. But if you look more closely, you see that it's still AF behind the sinus rhythm. So the right atrium is in sinus rhythm, and the left atrium is now still in atrial fibrillation, which you also can see on the tracings down there in the coronary sinus. So electrical isolation of the left atrial appendage, something that we do sometimes intentionally as part of an ablation strategy. It can also happen unintentionally. If you mistake the appendage for a pulmonary vein, it should not happen, of course, but it can happen, or for other reasons when you ablate just the last conducting fiber to the left atrial appendage. And importantly, these patients, after isolation of the left atrium, are at a high risk of thromboembolism, and I think we should always close the left atrial appendage in these patients. And if I do it intentionally as a part of an ablation strategy, I try to do it beforehand, so occlusion first and then ablation. Of course, if you do selective isolation of the left atrial appendage or unintentionally, you probably have to do it sequentially. So that's my summary slide. So these are my thoughts on how to implement ablation strategies into the sequence, how to do LA occlusion together with ablation, and I'm happy to take questions. Thank you.
So how frequently are you using concomitant procedures now in your practice? Is that occurring frequently? So just for context in the US now, the Boston's saying that about 40% of the left atrial appendage closure cases are concomitant, and we have reimbursement for the combined procedure, although physicians get paid only half for the left atrial appendage closure. The hospital gets paid full boat for both. So the reimbursement's there in the US.
Yeah, thanks. That's a very good question. Obviously, it's not the same situation in Europe. So we have reimbursement in Switzerland, but I think Alone AF and Ocean have kind of tricked it the other way again. So we're doing maybe 2 to 3 cases a month at the moment. So it's not something that we do on a larger scale like in the US.
I'll be curious to see if it pulls back a little bit in the U.S., particularly for some of the lower risk patients and whatnot in the wake of Ocean and Alone.
You showed nicely, Laurent, these scary visual images of interference of a pulsed field with metal structures, not only LAA occluders, but anything metal, ICD leads, occluders, whatever. do you think there is an argument, if you do LAA first, even if it was done historically, do you think there's an argument to move away from PFA again in those patients, switch back to RF, maybe even regional RF, if you have dual energy catheters, to consider in the anterior region to avoid using PFA and then maybe only do PFA on the posterior wall? What is your practice in these patients?
Yeah, it's a good point. I think we don't know really what the clinical effect of this is. And actually, it also happens with radiofrequency ablation. That can also have interferences, and we don't really know what happens in those cases. So I think it's the same situation. So I try to really avoid ablation very near to an occluder, or also sometimes if you have a septal occluder and you ablate the right pulmonary veins, the same happens. Or if you have a patient who has a mechanical mitral valve and you ablate an anterior line, it's the same issue. So whenever that's happening, I try to avoid ablation when I see artifacts on the EGM before ablation. And for example, if I have a catheter that enables me to toggle between radiofrequency and pulsed field ablation, I'll probably use radiofrequency instead of pulsed field ablation if it's possible at that anatomical location. So it's definitely something I want to avoid, yes.
Adel.
The option trial, which is the only randomized comparison between concomitant therapy and the medical treatment, it was done with cryoablation mainly, I think, and a little bit of, but no pulse field. So we have no randomized comparison between concomitant with pulse field versus, I would say, the standard of care. So do we need more? A new randomized trial? Do we need how can we certify the safety of combined ablation with the pulse field, since we don't have a randomized trial with this technique?
Yeah, it's true that we don't have any randomized trial using pulsed field ablation, but I think in option it was radiofrequency and cryo, and it was always ablation first and LA occlusion afterwards. So I think you just need to isolate the pulmonary veins, and that has been proven that we can do that with pulsed field ablation better than with thermal energy, so at least as good as with thermal energies. And then I think the only issue is regarding the formation of edema, and it seems that it's probably more favorable after pulsed field ablation than after using thermal energies. So I think, for me, I think it's okay to use pulsed field ablation in those procedures.
I do think more trial evidence would be of real value, though. I completely agree. And I mean, we've published on this question also sequential versus concomitant. Is there an advantage to doing it all in one? Are there risks? And we've shown that the risks are slightly higher with a combined procedure compared to either alone. But when you combine the risks of the sequential procedure, we basically half vascular access complications, and we have a lot of the anesthesia-related things. So not surprising at all, right? So, but we need to, I think, establish that more definitively with trial data.
Sorry, with regards of these concomitant versus sequential strategies, we have a talk this afternoon, which is a research proposal focusing on this topic, which is concomitant versus sequential, and see your thoughts.
Okay, so I think it's time to wrap up our session. Once again, thanks to all our speakers, and we move on to the next session. Thank you.